Thank you so much, Vikram sir. A bright and sunny afternoon to one and all. And on behalf of Amravati IMA, I welcome each and every one present here. Our respected President, IMA President Rohankar sir, of all the office bearers, ADC, Dr. Vikram Deshmukh sir, the speakers, the galaxy of speakers we have today, and the delegates and the viewers. I welcome you all to this wonderful webcon, which we are going to start right now. And as I have already mentioned, we have a galaxy of speakers from different specialities of our medical field. And they are Dr. Ashish Ganjare with the topic Recent Trends in Treatment of COVID 19, Dr. Lalit Raut with the topic Crisis in Sickle Cell Patients, Dr. Saili Jahagirdar with the topic PPH Bundle, Dr. Amit Kavimandan with the topic Non-Alcoholic Fatty Liver Disease, Dr. Shripad Jahagirdar with the topic Picky Eaters, What Parents Can Do, Dr. Kshitij Patil with the topic Aesthetic Rhinoplasty, and Dr. Dinesh Thakre with the topic Death Certificate in OPD Setup. So stay tuned and we begin now. So may I request the first speaker, Dr. Ashish Ganjare, sir. A short introduction of Dr. Ashish Ganjare. He has done his MD anesthesia from Tata Memorial Hospital, Mumbai. He has done his fellowship from PD Hinduja National Hospital and Tata Memorial Hospital, Parel, Mumbai. He has worked as a consultant at Critical Care SIMS Nagpur and Sunflower Hospital, Nagpur. At present, he is a consultant at Critical Care of Aureus Institute of Medical Sciences, Nagpur. So please welcome the director and founder member of Aureus Institute of Medical Sciences. And his topic is recent trends in treatment of COVID-19. Over to you, Ashish Ganjare, sir.
I will going to start my topic. Yeah, everyone is able to hear me. Hello.
Yes, sir. We are able to hear you and we can see the presentation, sir.
Yeah. Now, today I'm going to talk on this recent trends in transmission, diagnosis, and prevention and imaging of this COVID-19. If you see that what is the basic background behind this C19 is this coronavirus is initially identified as a pneumonia virus in Wuhan, and it was named as a SARS-CoV by WHO on 12 Jan 2020. It's basically originated from the local seafood market in Wuhan city, China. And what they found, the most common infected patient, what their clinical symptom is around more than 60 to 70%, they reported with the dry cough, and around 30 to 35% presented with a wet cough. And this cough is a major transmission of this COVID-19 infection. If you see the clinical symptoms, as this is a zoonotic origin virus, what are the primary symptoms? Mostly the fever, fatigue, dry cough, sore throat, sputum production, muscle pain, respiratory problems. These are the clinical symptoms. On the lab base, what they found is the around 70 to 80% presented with a lymphopenia, and around 30 to 35% presented with the leukopenia. If you follow this lymphopenia, like if you look after every time those patient while managing, alter neutrophil lymphocyte ratio. Hello.
Yes, Ashish, sir. We can
Hello.
hear you, sir.
Yeah.
Ashish, sir, we can hear you.
Yeah, sorry, just I'm not able to see this side. Yeah. So what on clinical basis, if you see this lymphopenia symptoms, practically the patient presented those who are in a very bad situation or in a clinically deteriorated, severely hypoxemic. If you monitor this neutrophil lymphocyte ratio, you will definitely find out those patients who are critically ill, they will have the significant lymphopenia. And as the patient clinically improve, this lymphocyte count also improved very well. Now, what is the current situation? If you in a current situation is around of this coronavirus infection, the present scenario from that old scenario from January 10 to 13th March 2020, there were around 7,52,000 reported COVID-19 cases. Out of those, around 36,000 deaths noted around the world. And that time, if you see on the world meter of corona, there's a mortality rate was very high, around 15%. And this, as this mortality was definitely significant, but as the treatment procedure was aggravated, the mortality rates were reduced significantly. And the current mortality rate was around 10% among the positive. But this, if you see again now, is a, from today's point of view, I will give the exact data of how many patients got get infected. The if the from the today's, sorry, I'm sorry for the interruption. I think just because of some calls, I'm not able to run the slide. Hello. Sorry, I'm not just able to run a slide. Give me 1 minute. You are able to see this slide, current situation in India? You all?
No, sir, we cannot
Hello?
see the slide, sir.
I'm also not able. Sorry, I don't know what is happening. They're unable to see the slides.
Sir, just stop the screen sharing and on it once again, sir.
No, sir. Hello. Hello.
Yeah, technical snags do come, and
Sir.
I request Ashish sir to go ahead without the presentation also.
Yeah.
Even that
Okay.
would be fine.
Just okay. Okay. Yeah. Uh, so what is like this current situation in the world? If you see, there were around 66 crores, around 86,000, 80 lakhs patients positive from today, and around death is around 15 lakh, around 34,000 for today. And if you see the current situation in India for today is around 96 lakhs 44,000 patients were positive. Out of those, around 140, around 1 lakh 40,000 has got a mortality due to corona, and recovered around 91 lakhs patients recovered. If you see the basic structure of C19, this COVID-19 looks similar to SARS-CoV that originated from the bats. There were few samples which revealed that this spike protein content of this SARS-CoV-2 is not a bat beta coronavirus, or not from the pangolin of beta coronavirus. And no animal virus look the same as COVID-2. Besides, again, there is some mutation in this spike protein which makes COVID-2 binds with the human AC2 inhibitor. Again, the progenitors of this COVID-2 jump to humans without being detected. And again, it was transmitted rapidly from human to human. That's why the similar from COVID-1 to COVID-2, this acquired this receptor binding protein domain, plays a role in a mutation during transmission into the cell, where the study revealed that this COVID-2 is not purposefully modified virus. If you see this COVID-19 family, it's an order of nidoviral family. It divided into the family of four: artriviridae, coronaviridae, mesonaviridae, and roniviridae. And this coronaviridae divided into again coronaviridae and toroviridae group. And this coronaviridae divided has got a genus of alpha, beta, gamma, and delta COVID. If you see the transmission of this COVID-19, the transmission takes place mainly through human to human during intimate contact with each other. And in early period, it was reported that this coronavirus affected near about more than 72% of these resident people around that area. And around 30% had travel history from the Wuhan, China city. Again, this recent research has pointed out that human proximity and social interaction increases this transmission of this virus. Among the several rates of transmission, the droplet are the primary source of transmission. Again, the picking the contaminated surfaces and touching face increase your risk of getting infected. In recent spread of infection through stool, they have also confirmed it transmit this virus. Again, in some cases, they also found the ocular surface is again responsible for this transmission. If you see the role of hand hygiene, what they found out that if you wash your hand at least 5 times per day, it significantly reduces your overall infection rate. The incident rate drops below around 0.35 with a significant p-value. And if you wash your hands after cough and or sneeze, it definitely minimizes the risk of transmission via household project. And there's again, it has got a significant incidence rate ratio on the lower side. There is a reproduction number, what is called the transmission of this virus from one person to other. For this coronavirus, the WHO defined initially this reproduction rate was around 2 to 3.5. And now for the today's scenario, in India, this reproduction rate is varied between 1.2 to 1.5 transmission rate. And in UK, it is around 1.1 to 1.3. This transmission of this since 19, the average personal aerosol transmission is a major source. If you person stand between 4 to 5 feet, social distancing, that's why they recommend it should be at least 6 feet to avoid the transmission from one patient to other person. But in some countries, what they follow the rule, like in Australia, they are following 5 feet rule, 5 feet distance rule. In Denmark, France, and Lithuania, they follow the 3 feet rule. In one of the study, what they found out that there is a 13% risk of getting infected if the distance between two people is around within 1 meter. That means around 3 feet. And as this distance increases beyond 1 meter, there is a significant drastically reduce this transmission of the disease around 3% every increase in a 3 feet of distance. What are there are certain guidelines WHO defined for the medical personnel who are treating this infected patient. What they said, the medical staff who are treating infected patient should be isolated. Their routine activity must be monitored, and if they witness any problem such as fever, cold, cough, they need to be quarantined. The team of officials must check whether these medical personnel are following their preventive measures proper or not. Yeah, if you see this C19 virus, how many hours it remains alive in the surrounding area? What they found out that they live in the air for more than several hours. It can remain intact on the surface for more than 2 to 3 days. And further, again, what they observed, this virus could live up to 4 hours in copper and 2 to 3 days in a steel surface area. But in plastic, they may live longer. That really we don't have the enough. But there was no evidence for the cloth exposure, how much time they remain on the cloth. The WHO also come up with the transmission of C19 through the eyes. What they give some certain guidelines for this ophthalmologists. They said that this ophthalmologist should take proper precaution of maintaining hand hygiene, personal protection, as per prevention of this infection of SARS-CoV. This exposure of virus to the ultraviolet radiation and heating can control the infection. They again advise how you will sterilize. Means if you sterilize the instrument for more than 56 degree for 30 minutes with a lipid solvent, can make the ophthalmic instrument safe for the transmission. They put some certain guidelines for the dental procedure also, because they are exposed to patient very close in proximity, exposure to the saliva, blood and body fluid. What they advise them, they should follow strict hand hygiene, use their personal protective measures properly, mouth rinse before the dental procedure. Knowing this travel history of the patient, they should document it. They also suggest for the anti-retraction handpiece, disinfection of the clinical setting, and handling of the medical waste properly. They have given certain guidelines for the endoscopy procedure. Like they advise like equipment should be used, mask, gloves, goggles, gowns, shield, and other respiratory equipments for the to prevent this outbreak of C19 from the patient. But the key ways of possible transmission during this endoscopy are mostly due to human contact, either droplet, air, and body fluids. What WHO said, and what the IDC guidelines also suggest, the transmission of this COVID-19 in pregnant woman. What there's a certain article by Liu et al. What they found out, the pregnant women being are more susceptible this COVID-19 infection, but they reported no vertical transmission to the virus. But currently, again, we don't have the exact data 100% proved, well proved that there is no vertical transmission. It's still not 100% true. But the what he found out, breast milk sample. Yeah, sorry, I think you will able to see the slides now. Hello. Yeah. Hello. Yeah. What I now you see the
Yes, sir.
slides
We are
also.
able to see the slides, sir.
Yeah. There's a guidelines which I told you for the endoscopy procedure. What you have to follow. You have to just see the mostly you have to use your personal protective equipments while doing the procedure. And what are the basic methods, key ways which transmit the infection to the or consultant or our doctor through human to human or droplet or air, body fluid, transmit this COVID infection. And then transmission of the C19 in pregnant women. What Lee and et al. What he found out, the pregnant women are more susceptible to this COVID-19, and they reported there's no vertical transmission of the virus. Breast milk sample tested negative for the virus, and that's why he denoted that the breastfeeding can be done. Those patient mother got infected with the COVID-19. Sorry. Sorry again, I think. Yeah. You are unable to see the slide. I don't know what is happening. What they suggest is a diagnostic method and procedure to prove the C19 infection. The IgM and IgG is the simple technique which perform to diagnose this infected person. And what they found that IgG reported around 72% of detection rate. Beside nucleic acid test reported around 87.5%. And again, high sensitivity C-reactive protein, it is better with the nucleic acid negative group observed with a higher test positivity. That's why finally they said IgM and IgG are definitely better over the nucleic acid detection test, as it is highly recommended. Then second diagnostic procedure we are doing for the C19 is the CT image. They divided CT image into stage 1, stage 2, stage 3, stage 4. In stage 1, what we found out, like maximum patient number of patient with observed with a ground glass opacity around 75%, and lesions in a single lobe in stage 1, and consolidation. This is around most commonest feature. In stage 2, what they found out in CT, consolidation followed by crazy paving with multi-lobe involvement, and peripheral lesions may be there. In stage 3 of CT imaging, we will able to get peripheral involvement, bilateral multi-lobe involvement, ground glass opacity, and consolidation. And in stage 4, the peripheral plus bilateral multilobe involvement, ground glass opacity, consolidation, and crazy paving pattern. If you compare what are the best side tests we have available, like X-ray, CT, and ultrasound. In X-ray, the ground glass opacity you may able to see, but it's still not that sensitive. Compared to CT is much more sensitive. And in ultrasound, if you want to do the bedside for like evaluation, you will able to find out pleural line thickening and increase B line and consolidation of the air bronchogram you can able to see on the bedside UAG. If you compare CT finding versus RT-PCR, the definitely CT scan preferred over the RT-PCR when the patient carries the clinical symptoms of such as shortness of breath, cold, fever, and diarrhea. On the other end, the correlation between the RT-PCR and CT scan be done to make sure the infected patients after the complete recovery. Sometimes you will get the false negative RT-PCR. The reason for this false negative RT-PCR either due to the insufficient viral material or laboratory error. Immature nucleic acid may be responsible for this. Insufficient viral load may be lead to the false negative RT-PCR, or improper clinical sampling also possible, or those patients with a low detection rate, and sometimes the manufacturing defect may be there. There are certain molecular assays evaluated for this COVID-19 diagnosis in US, in China. The Center of Disease Control and Prevention, they extensively working on this assay to target the genes like one, open reading frame 1B, second, RNA dependent RNA polymerase, third, non-structural P14 for the detection of COVID-2 with a high accuracy. And recently also about come up with a, sorry, just like, that's why again, as I told you, CT image comparison between the X-ray and CT ultrasound, CT versus PCR. I have told you, and what are the reasons for this false negative RT-PCR? And as I told you, these certain molecular assays are developed, and recently this Abbott also come up with the ID now, for now TM COVID-19, which can deliver the result within 5 minutes by targeting this RNA-dependent RNA polymerase gene. As a sum of this, where in China, which type of your genes we are using this immunoassay, and this is called molecular assay we are using for this COVID-19. So, sorry again, you lost the. Then again, I'm unable to show you the slide, but this what is the outlook of this clinical procedure and treatment? The currently we have the 15 drugs which initially identified this, which we are treating for the you are using to treat this COVID-19, like chloroquine, hydroxychloroquine, lopinavir with ritonavir combination, napstostat with camostat, with famotidine, unifavir, ivermectin, corticosteroid, tocilizumab. Sometimes they again human immunoglobulins are also playing certain roles by they are containing natural antibodies and protein which representing the first line of defense against this pathogen. uh, what they found out in recent reports, the dexamethasone and remdesivir drug was widely considered as a life-saving drug because they have studied in more than 1063 patients. It was convinced that this remdesivir is significantly reducing the symptoms and recovery time of the adult with the COVID-19 infection. But Indian scenario, definitely remdesivir is concern for us because of their cost availability. uh, so now, what is the prevention point of view, the vaccines availability? Currently, if you see the so many vaccines research is going on. Final first vaccine sanction got in UK is the Pfizer vaccine. This is the first one, and the second one is with the Moderna. They are also in the phase 3 and near sanctioning process. And if you see the in India, we have the Oxford vaccine in it's in a phase 3 trial and may get sanctioning within 10 to 15 days. Today, the news came that the Pfizer directly come up with a vaccine availability without going bypassing the phase 3 trial, and it may be available in Wardha, Savangi for from next week, either for the phase 3 or a direct inoculation. Really, that I don't know. This is the current scenario of the COVID-19. Thank you very much for IMA member. And I really, because of this technical reason, I'm unable to show you the slides. Hello. Thank you, sir. Vikrant sir. Thank you, Morko sir.
Hello.
Hello.
Thank you so much, Ashish sir.
Yeah.
Thank you for adding to our information about COVID-19 infection. And in spite of the technical glitches